Hello everybody, welcome to my YouTube channel, Nurses Simplified, and today we are going to talk about one of the very asked topics, that is portal hypertension. Before we start on to that, please subscribe my channel if you haven't done so. Okay, before we go into the details, let's have a basic look of the anatomy and physiology. Now, the anatomy, which says that the liver is placed in the right upper quadrant of the fifth intercostal space. It has two lobes, which has independent vascular and duct supply. We will not go into much discussion about it, but what we want you to know is that liver has its supply where all. Now, liver has supplies two sorts of, it gets two supplies from both hepatic artery and the portal vein. Now, when it comes to hepatic artery, what we want you to know is that the hepatic artery supplies around 20% of the blood and oxygenated blood to the liver, and on the contrary, our portal vein, it contributes to around nutrients and toxins from the GIT, pancreas, that is a gastrointestinal tract, your pancreas and spleen and gallbladder, to the liver. And everything is well processed, and from the hepatic vein, this processed nutrients, toxins and pathogens, they go to the IVC for systemic circulation. Okay, so what I'm trying to explain here is that like other organs, what they do is that they go from their organ, it goes to the heart for circulation through the IVC, and into from the atrium to the ventricles, and then into the pulmonary circulation, onto your pulmonary circulation for your blood purification. And then, but there is the liver, what the liver does, it bypasses one area where they use the liver also. So all your GIT, gastrointestinal tract, and your pancreas and your spleen, they use the liver for the process of purification or detoxification, and with that help they go into the liver, and from there they go into our main areas. Now we will move on to the portal circulation. So what I just explained to you, that is nutrients, they are from the diet, except for the lipids, they are absorbed from the small and the large intestines. They move into the superior and inferior mesenteric vein, from there into the hepatic portal vein, and from there it will move into the liver. Some from the stomach also, same thing. Nutrients are absorbed, they move into the gastric vein, then into the portal vein, then into liver. And the spleen also, it has this erythrocytes or other blood products. They are broken down. Basically, the part of filtration is done in the spleen. So the breakdown of the spleen products of the spleen, that is erythrocytes, they move into the splenic vein, portal vein, then into the liver. Just pictorial we have seen here, that this is your portal vein, and sorry, this is your portal vein. From the gastric vein, from the splenic vein, from inferior and superior mesenteric vein. So this is your GIT, this is your gastric, and this is your splenic vein. They move into the portal vein, where they divide into the liver sinusoids, and from there they just they move into the IVC for circulation. Okay, so next we move on to that is what happens in a normal portal circulation. Now, what happens when there's a hypertension in that? That is used to describe an elevated pressure in the portal venous system. It should be at least 5 mm of Hg higher than the pressure in the inferior vena cava. Now, what are the causes? We have divided it into pre, intra, post hepatic. So pre-hepatic is basically because of portal vein thrombosis, and we have portal vein stenosis. Along with that, we have splenomegaly, or we have something called arteriovenous malformation of the splenic vasculature. So apart from that, what happens inside the liver now? Inside the liver, what happens is that there is cirrhosis of liver, which is an obvious cause. Liver diseases like chronic hepatitis, and we have something called a granuloma or the sarcoidosis, and hepatic vein obstruction. And in the post-hepatic, we have something called hepatic vein obstruction. It can be an IVC obstruction itself. Now, we have other causes which are not related to liver, that is schistosomiasis. This is one, it is a parasitic disease, and this can lead to portal hypertension. Why? Because of the hepatosplenic or because of the periportal fibrosis caused by these parasite eggs, which obstruct the whole blood flow in the portal vein, and that elevates the pressure in the portal hypertension. Next, we come to idiopathic non-cirrhotic portal hypertension. Say some inheritance other than that, right-sided heart failure or complete heart failure, constrictive pericarditis. Now, portal hypertension pathophysiology. What happens is that we have a prehepatic or intrahepatic or posthepatic, whatever cause, that leads to an obstruction. Now, this obstruction leads to prevention of blood flow towards the inferior vena cava. How? Because this accumulation of venous blood in the portal and that accumulates the venous blood in the hepatic portal system, and that leads to increased blood pressure in the hepatic portal system, and that leads to hypertension. Because of this obstruction itself, there is diminished blood supply to the liver, and this reduces the liver function, and therefore its detoxification work is not happening. So the ammonia, which is supposed to be detoxified by the liver, it is not detoxified. And what it does, it starts accumulating. Now, accumulation of it in the blood increases, and then what it happens is when that increases to a certain level, that crosses the blood-brain barrier, and that leads to something called a hepatic encephalopathy. Now, because of this, there are some patients will come to you with confusion or disorientation, and mood changes or impaired judgment. Now we come to something called a portal hypertension. What happens in case of anemia? Um, why we have this anemia because of portal hypertension? Why? Because it that leads to elevated pressure in the portal vein, right? And that leads to splenomegaly. Why? Congestive splenomegaly. Blood is backed up to the spleen, which should be going to the liver. It goes back to the spleen. So now your spleen start becoming hypersplenism. It does not it leads to congestion within the spleen, and the spleen starts becoming overactive, removing too many blood cells from the circulation, and that leads to complications like bleeding, bruising, and so on. Now we come to something called how portal hypertension leads to ascites. Because the endothelial cells lining the blood cells, they release something called nitric oxide that increases, and that dilates the peripheral arteries, and the plasma volume expands, and fluid in the blood vessels, they get pushed into the surrounding large spaces like a peritoneum. Clinical features are very easy to identify because as we know that it is basically divided into A, B, C, D, and E. So what is A? A is ascites, bleeding, as I told you the reason. We have something, a new term called caput medusae. This is a caput medusae. What do you mean by caput medusae? It is an appearance of like distended or engorged superficial epigastric veins, especially from the umbilicus across the abdomen. So the caput medusae originates from the apparently from the Medusa. It is like a mythological figure basically, but the main thing is like it starts having this engorged vein, that is caput medusa, and diminished liver function and enlarged spleen or splenomegaly. Some other features, as you can see here, are coma, fetor hepaticus. Fetor hepaticus is like a smell of a corpse. Spider nevi, gynecomastia, jaundice, ascites, loss of pubic hair, testicular atrophy, and liver flap, that is asterisk sign, which we learned in cirrhosis of liver, bleeding tendency because of the decreased prothrombin, and anemia because of splenomegaly, ankle edema. And other than that, we have esophageal varices. So patient present to you with hematemesis, melena, ascites, rectal varices, that is called your hemorrhoids. Now we have we have to discuss something very important, that is called the diagnosis. How do you diagnose a portal hypertension? The only method is most confirmatory method is a HVPG, or what we call as a hepatic venous pressure gradient. What is it? It is to see the gradient in the pressure between your portal vein and your inferior vena cava. Now, what we do is we try to see the degree of portal resistance or the sinusoidal resistance to the blood flow in this HVPG. Now, what I want you to know is that normal HVPG is 1 to 5 or 1 to 4. How do you say someone has a portal hypertension? Is if you see more than 6. Clinically significant, if it is more than 10, you will see patients having esophageal varices. And if it is more than 12, it is severe. So, patient will come with variceal bleeding and ascites. Now we have something called another diagnosis we can confirm through ultrasound, that is duplex ultrasound. What we are trying to find out is your cavernoma or thrombosis, and also we can use abdominal CT scan to again find out for thrombosis or a dilated bowel, or you can even find out ascites. We have transient elastography. We don't want you to know too much, but what we want you to know is like it's an M-mode image in the monitor, and you will see that in a normal patient it will be 3.5, but in a cirrhotic patient you will see 33.3. So it is quite variant, and normally it is very slow. The wave they will see is very slow, it's okay, but in a cirrhotic the wave will be very rapid, very progressive. That is the only thing that we want you to know. And other than that, we have also EGD, that is esophageal gastroduodenoscopy. It is diagnostic as well as therapeutic to identify esophageal varices. And other than this, we have lab tests, that is your ammonia liver function test to find out, probe into more into the diagnostic criteria. Now we come to something called a treatment. That is, how do you treat um, esophageal varices? The only and the best line of management is always beta blockers. The first line is always beta blockers, something like a non-selective beta blocker, like a propranolol. Why? Because it inhibits your beta 2 adrenergic receptors in the GI tract, and in that way it will help in the splenic vasoconstriction. It decreases your portal and collateral blood flow, and you're decreasing your portal hypertension. That is what it does. Other than that, it is also known, or it is very helpful in your treatment of varices, esophageal varices as well. So it is very helpful in that way. Now we come to something called diuretics and sodium retention. Why we use diuretics is also because it is also helpful in reducing the total overload, so it will not allow the sodium to be retained. So in that way there will not be fluid overload, and thereby you can help. Next, why we give, you will also hear a patient of cirrhosis of liver getting something called an octreotide. Now, octreotide, it is nothing but a somatostatin. What is somatostatin? It is an effective therapy for esophageal variceal bleeding. And the same process, it will cause vasoconstriction, splanchnic vasoconstriction. So the small intestinal variceal bleeding can be stopped. Next, other than octreotide, it is like a small injection, I think, of 1 ml somatostatin, and that is very helpful in controlling variceal bleeding. Now we have something called a banding, or we very commonly call it endoscopic variceal ligation. It is a procedure to prevent the bleeding from the varices again. Now, basically, what we do is we insert an endoscope or a thin flexible tube with a camera, and these bands are tied around the varices. So it strangulates them basically, thereby reducing the blood flow, stops the blood flow, and thereby the bleeding. Now, other than that, we'll also hear something called a sclerotherapy. You will come across one term or one word being used, that is a SB or SB tube. So what is when you will hear such things, just use your just use your intuitiveness to understand. It is also to treat your esophageal varices, and this procedure is basically there you are using a sclerosing agent here. We're not using a band or a tube. We're using a sclerosing agent, which is also passed via a flexible endoscope. And you don't have to know the medicines that are injected. Basically, they are all sclerosant agents, and they help in again controlling the bleeding. That is what we do through a sclerotherapy. Now we have something called a balloon tamponade. Now, how does a balloon tamponade help in varicose, in controlling varicose bleeding? Is we use a special kind of tube called a SB tube or a Staken Blackmore tube, whereby uh, we um, uh, we use these balloons, um, one from the stomach and one for the stomach and one for the esophagus, and we inflate these balloons, then pressure is applied, and then this stops the hemorrhage. Now we come across something called the surgical shunt. Other than this, we also use surgical shunt. Now, how is a surgical shunt working? This is like a needle catheter which is inserted via our jugular vein, internal jugular vein. It passes the hepatic vein, and then it passes through the liver into the portal vein. And this expandable metal stent is placed, and a side to side portacaval shunt is made. So the stent or the shunt, it bypasses this liver sinusoids, and the blood drainage from the portal to the systemic shunt is maintained, but at the same time your portal pressure is also coming, you're decreasing your portal pressure, so your liver doesn't have to do much here. It is like a portacaval shunt basically. So this is all about portal hypertension. If you have any doubts, or if you want to know anything more, or any area which you need clarification, please comment below. I'm more than happy to explain, and see you in the next session. Till then, just go through my channel and go through its content and let me know your positive feedback. And please to subscribe and stay empowered. Bye bye. Take care.